so we'll jump into chapter 13. So chapter 13 is going to be about infection and disease. And then chapter 14 is about epidemiology. All right. So infection and disease. Infection is when we have growth of microbes either in a place they don't belong or overgrowing in amounts that they don't need to be overgrowing in. So this could be, one example could be, let's say that you are a woman and you aren't practicing proper hygiene when you're going to the restroom, and you wipe, instead of going front to back, you're wiping from back to front. As a woman, you probably learned like it's actually pretty important that you're supposed to be wiping from front to back. That's because urinary tract infections in women, 80 to 90% of urinary tract infections are caused by E. coli from your own colon. 80 to 90%. Okay. E. coli from your own colon. This could be from poor hygiene practices, or it could just be from sexual activity. There's a lot of mushing around going on down there. And so you might want to flush that out by urinating so that those E. coli bacteria don't migrate up the urinary tract, right? So, but that E. coli, it belongs in your body. It just doesn't belong in your urinary tract. And so that is an example of something where the E. coli originally was just a normal, co-inhabitant with you, as part of your biome. Once it gets introduced into your urinary tract, now we have an infection, growth of bacteria that doesn't belong there, right? Infection. Now you can have infections and not have disease. Disease is deviation from health. We call it a pathologic state. So we have basically some signs or some symptoms that are associated with damage being done to the body, either by the microbe or by your immune system in response to the microbe. So once you start having signs or symptoms, then we consider that disease. So deviation from health. You start getting that little tickle in your throat. You start having a cough. You start feeling really tired, or your muscles get sore. Things like this that could be associated with having an infection. That's disease now. It's a pathologic state due to the infection. A third of all people who are infected with COVID, a third of them don't have any symptoms at all. They're asymptomatic. So that's an infection, but not disease, right? All right, normal biota, we know that we have microbes in and on our body that do jobs for us, and they can consist of bacteria, fungi. In particular with the fungi, we're mostly talking about yeast here. Yeast are a normal part of our biome on our skin and in our reproductive areas. So these are not anything to be considered pathogen just because they're there. So we're to have them in small numbers. Protozoa can also be part of your biome, and there's a lot of viruses that we're now discovering that are part of your biome naturally. There's a lot more work that needs to be done on studying those guys and their effects on our biome, but they might not be associated at all with any sort of disease. The only ones that are one of the groups of organisms that we learned about that are not part of our biome will be the helminths. You should never have helminths in your body. Any helminth ever will always be a sign of an infection. So you plus all of the organisms that live in and on your body, that's the holobiont. So it's not just you living in this body, it's also bacteria and protozoa and fungi and viruses. So you plus all of those organisms, holobiont. You might have you plus your resident microbes. We can also have introduction of potential pathogens or presence of transient microbes. So again, example of a transient microbe. If I go outside and I sit in the dirt to enjoy myself like a nice little picnic, just a nice day outside and whatever, and I drop a chip on the ground and I decide to eat it, am I always 100% going to get sick from doing that? Probably not. Like 90% of the time, probably you can drop food on the floor and not get, well, maybe not the floor, but you'll be outside and it could contact the outside, God forbid, or your countertop. Is your countertop sterile? Probably not, right? So when your food touches your countertop or your plates, which are also probably not sterile, or your hands, which are probably also not sterile, right? And you can eat that. You're not always going to get sick from that. Most of the time, your body's going to just get rid of those guys. Those are transient microbes, okay? We also have our potential pathogens, where if they are in high enough number, could potentially take up house in your body as an infection and could potentially lead to disease. But for example, with salmonella, it takes 50 salmonella bacteria cells in order to cause salmonella disease. So if you only encounter one or two in that nice runny egg yolk that you like, I love a runny egg yolk, but if you only have one or two salmonella bacteria in your undercooked eggs, you're very unlikely to get a disease from that if you have a healthy immune system. So then those potential pathogens will just be transient microbes. Your body will probably get rid of them. You need at least 50 for them to set up house as an infection. But once they do set up house and start growing in your body, now you have an infection. An infection then potentially could lead to your immune system recognizing it, leading to inflammation, leading to fever and things like this. That would be disease, all right? Sometimes you're able to clear disease, sometimes not. There's only two routes you can go once you get sick: death or you get over it. You either get over the disease or you die. That's the two choices, all right? If you have a chronic infection, you're like, no, some people just don't get over it. And I was like, well, that's not, they're still infected. They still got the disease. They haven't gotten to the end of that. So once you've gotten over the disease, you either get over it or you die. That's the only two options that you got there. And so actually a pretty strong tenet in epidemiology as far as how they assess things. All right. The Human Microbiome Project was set in place to try to figure out what kind of microbes are where in your body. I'm not going to go over any more than that. We also have benefits from the microbes that live in our body. They might influence how your organs develop and train your immune system on what's foreign and not foreign, and what you should be reacting to and what you shouldn't, and when and how and where. So they're actually pretty important in the development of your body. They're also very important in helping you digest your food. We know that your microbes live in your gut and help you digest food. But it's actually so important that if you didn't have microbes in your gut, you would probably die. Like, your gut depends that heavily on microbes being there to help you digest and absorb foods. And so those microbes that are in your gut are extremely important for providing that benefit, but they also are going to take up our stadium seats. And what I mean by that is, imagine you have Boone Pickens Stadium, you've got all these seats there, but we have microbes that live in your body taking up those seats. So now the pathogens can't find anywhere to sit down. This could be literal physical taking up those seats, or just taking up the nutrients in that area to where the micro bad guys can't find any nutrients in order to take up house there. So they could be taking up the actual physical space. They could be stealing up nutrients, or they could be actually making defenses up against potential bad guys. So toxins and antimicrobial, byproducts that could fight off any potential bad guys moving in. That whole process of them being defensive for us is called microbial antagonism. That's when our normal biome helps fight off the bad guys, basically just by being there. We know there's a lot of factors that can increase your risk for infection. Being too young or too old, you've got a weaker immune system. You've got cancer, or you've been going through surgery, you have a lot of stress on your body, or maybe you've been through a treatment that clears out your normal biome. All of these things can make you more susceptible to infection. We have a couple of different kinds of infections that you can have: endogenous and exogenous. Endogenous infections are caused by biota that are already in your body. This example was like the one with your UTI infection, or my UTI. It doesn't have to be you, right? But the person's UTI infection. So this came from their colon. That was already an organism that was basically involved in their microbiome in their colon, and now has moved to somewhere else in the body. It came from within their own body. Another example, you get the flu. Influenza is a virus that came from outside the body. Exogenous infections are the ones that come from outside. You're not ever going to have the flu sitting somewhere else in your body and then moving into another area of your body causing the flu. It's never going to be part of your normal biome. This is always coming from outside, just like COVID or tuberculosis or the plague. These things are always going to be things that cause disease. They're dedicated, that they're pathogens always. They're called true pathogens. So endogenous infections, usually these guys are what we would consider to be opportunistic pathogens. And so they're just taking that opportunity. So let's say you get the flu, all right? That's an exogenous infection. It came from the outside. And now you have damage being done within your respiratory tract as your body tries to fight off the flu. Your immune system and the flu itself causing damage in your lungs. Well, it's going to make you more susceptible to other infections, right? So this could be things like pneumonia, like what we have here on the screen. You can house Streptococcus pneumoniae, which is the #1 cause of pneumonia in the world. It's also the #1 cause of meningitis in the world. Okay, it normally can take up house in like your sinus cavities, and it's happy there in small numbers. But now suddenly flu has come along and caused damage in your lungs. It may have disrupted the biome in your lungs, as well as made new stadium seats. We've created new pockets, new niches that the bacteria can now take up house in. And so now Streptococcus pneumoniae that might live in small numbers in your sinuses, as you're having sinus drainage, moving into your lungs and now taking up house in your lungs and leading to pneumonia. That would be a secondary infection. The flu itself didn't come out from inside of your body, but that strep pneumonia that's giving you the pneumonia might be what's dangerous. The pneumonia could be what kills you and not the flu itself, right? but the fact that you had the flu set you up for it. So the pneumonia would be an endogenous infection caused by the effects of the original exogenous. Also, you have your UTI, let's say, back to that. You take antibiotics to kill off the bacteria that are in your UTI, and now you've killed off all the bacteria that are in the vaginal area as well, perhaps, right? And now what's left if you killed off all the bacteria? The yeast. Yeast are not bacteria, they're fungi. You don't kill yeast with antibiotics, you kill them with antifungals. And so now you've killed off all the bacteria and you've left all these stadium seats open. And now the yeast can overgrow. That's an endogenous infection, right? It's not, and now it's an infection because you should only have them in small numbers, and now it's overgrown. And now we have signs and symptoms of the itchy and an inflammation that's associated with having a yeast infection leading to vaginitis. You could also have a shift in the actual bacterial biome. So you get your UTI, and because you're trying to treat it with all of your weird orange pea pills and all of these things that we take in order to get rid of UTIs and deal with the symptoms and signs, that you might shift your biome that's normal in the vagina to favor bacteria that normally aren't that high in number. And so then you can have overgrowth of the bacteria, and that can lead to bacterial vaginosis. And so that the levels of what bacteria are there and when and how much yeast there is and when and how and all of that is a very delicate balance that needs to be maintained by, taking care of our pH, taking care of hygiene, and then making sure that our biome is at the levels that it should be in these areas. Otherwise, we can have endogenous infections of all sorts of different kinds coming from within your own body. So where do we get our microbiome from? Whenever we're building new cells for a new baby, it doesn't include building up your microbiome. I hate to break it to you. So that's always going to come from outside of the baby. So we do think that our primary, very first seeding of our microbiome happens in the uterus, but it's not by a lot. Okay, there's only going to be some microbes that you'll be encountering in the uterus. Most of your exposure is actually going to be through the birth canal and through breast milk after that. So if you are a baby that is born through C-section and you're being fed on formula that doesn't have probiotics in it, this is actually really common, right? To be born by C-section and then to be fed on formula afterwards. And that formula probably doesn't have probiotics in it. So bacteria, that would be good for your gut. That baby is going to be a lot more colicky. What does colicky mean? They're going to have GI issues. They're going to be crying a lot. They're going to be gassy. They're not going to be having normal bowel movements and things like that because their gut isn't actually adapted to deal with the milk that you're putting in them, the formula. They can't break it down because the bacteria that come with being exposed to the birth canal and to breast milk help break down the milk. You don't come with that pre-built. Okay, that's the bacteria in your gut that do that. So if you don't get exposed to that, you're setting that baby up for a pretty uncomfortable growth period until they can get their body seeded with some good healthy gut bacteria to manage that. So uterus first, then birth canal, then milk. Okay, and there's plenty of formulas out there that do have probiotics, so push that. There's nothing wrong with being born through C-section or having formula. Just be sure that the formula has probiotics in it, so some bacteria to help with the gut. And we have, of course, being exposed to your caregivers, your mom or your dad or your motherly or fatherly type figures, whoever's taking care of you, your brothers, your sisters, and whoever else would be handling you. And then your environment, like getting kisses from your dog or your kitty, going outside and playing at the park and things like that, exposing you to the environmental stuff and getting your body seeded with your microbiome. So that's where it comes from at first. But does it stop changing after that once you get populated? No. So when you go through puberty, pH changes and hormone changes are going to lead to a shift in your microbiome. And when you start becoming sexually active and you get exposed to somebody else's microbiome, you might incorporate that and mix and match there as well. So it really doesn't ever stop. Pathogen is any microbe that can cause disease. And we learned about that like chapter 1. True pathogens are those organisms like the plague, like COVID, like flu. These guys cause disease. That's what they do. They don't exist in conjunction with your body outside of causing disease. They are disease causers, and that's it. Even for healthy people, they'll cause disease. Opportunistic pathogens are the guys that will cause disease in somebody that has a weak immune system, or whenever they're put in a situation where they don't belong. Or perhaps you set up that situation by taking an antibiotic, right? So it's not abnormal to have C. diff as part of your microbiome. C. diff is normal in people's intestines in very small numbers, but you go and take an antibiotic or some other infection, and now it kills off all the microbes in your gut. C. diff will overgrow because it's a very resistant type of microbe because it makes endospores. So those endospores will be very resistant and resilient. And then you've gotten rid of all bacteria in your stadium seats and C. diff will overgrow. And now suddenly you have an infection of C. diff leading to pseudomembranous colitis. And it can be very dangerous and can be very easily spread throughout a hospital. So that's an opportunistic pathogen. It was just sitting there being fine as part of your normal microbiome, but now it's overgrown and led to a disease. Okay, so opportunistic, just like the E. coli that was in your colon that led to your UTI. It took the opportunity that it was given. Virulence is basically a measure of pathogenicity, and pathogenicity is like disease. So if you've got disease going on in the body, the measure of how bad that is, that's virulence. So anything that helps a microbe cause more disease type effects in the body is called a virulence factor. So this could be something like having a capsule to evade phagocytosis. That would help that organism create more disease in the body. Creating toxins. If an organism excretes toxins into its environment, those toxins cause damage to the tissues nearby, cause paralysis or whatever it is that they do. Those would be virulence factors. So anything that helps that organism cause disease is a virulence factor. An infectious dose is the amount of organisms that we need to cause disease. Like I told you with salmonella, you might need 50 of those guys to cause salmonellosis, whereas with COVID, you might only need one virus. Okay, so that's infectious dose. And what are the steps involved in causing an infection? Well, these are pretty straightforward, and we'll come back to some of the details on these as we go through the slides, but for the most part, I'm just going to review over them really quick. Finding a portal of entry, this just means getting in. This could be broken skin. It could be from eating something that's contaminated or from breathing in air droplets that were contaminated, things like that. Then establishing your basically like your home as a pathogen. So say attaching and negotiating the microbiome. We'll say set up shop. You got to make your space as an organism, right? So you got to attach somewhere. So for our guys, we learned about fimbriae as being like these little hair-like appendages on bacteria that allow for attachment. That's one way they can attach. Bacteria can also have capsules. So can protozoa. Those are sugary, sticky coatings. They help evade phagocytosis, but they also help with attachment to surfaces. We also have surface proteins or viral spikes. These are very similar, whether you're bacteria or a virus. These are basically like used for docking to certain parts of the body. Okay, so what allows us to get into our cells for viruses, but it could also just be, hey, this is, lets the microbe know, hey, this is lungs, this is where I want to be. And so they know where they're at too. All right, surviving host defenses. Most of this stuff means avoiding your immune system. So you're going to avoid the immune attacks. So this could be avoiding phagocytosis. So having a capsule helps with that. We've said it already like 3 times just today. But having that sticky coating makes it easier to evade the phagocytes, or white blood cells that would eat you up. Some of our organisms, they just like living in our phagocytes. So tuberculosis is an example of this one. Tuberculosis will get eaten up by the white blood cells in your lungs. They are called alveolar macrophages. These alveolar macrophages will eat up tuberculosis, and it is happy to be there. It'll say, thanks for giving me a house. Been looking forever for this one, high fives all around. And so it will stay living in those white blood cells, protected from the rest of the immune system, just happily existing inside of them. So that's one way that you can avoid phagocytosis, living inside of the white blood cells, avoiding the white blood cells, or some of our organisms literally kill the white blood cells. They have mechanisms that will allow them to do that. We also have some organisms that mimic our cells. They can have proteins on their surface that look like your self proteins. And so our body won't see them. It'll see them as self instead. Or if it does see them because they're just different enough, then it tries to make antibodies against the bad guys and it ends up attacking you also. So this is actually what happens with if you have strep throat that leads to like scarlet fever. Scarlet fever is when you get the rash from strep throat. You didn't know that. That's what that is. If it goes past the throat and starts making the rash on your kid, that's scarlet fever. And so when scarlet fever persists enough, the body will start attacking the strep bacteria, and that strep bacteria looks like your cells. And that can actually lead to the development of something called rheumatic fever, which is an autoimmune response. Your body's trying to attack the strep, but the strep looks like you, and it ends up attacking your heart instead. And so you end up having issues with the heart and having inflammation in the heart. It's transient and it can go away if the infection goes away. We actually believe that some autoimmune diseases came from our reactions to infections. And so we'll talk about that in chapter 17 when we get to it. All right, moving on, causing damage. So this is where we actually get disease presentation. The organism will end up living its life. The immune system will attack it and the immune system will cause damage. That's like most of disease, okay? Then when an organism gets into your body, it doesn't just make your fevers happen. It doesn't just make you feel sore and tired. Your immune system is reacting, and then that's leading to you having a fever, feeling sore and feeling tired and things like that. So your immune system does like 90% of the work on the feeling like crap side of things, okay? But in its efforts to attack the bad guy, it knows that you as a big multicellular organism will be able to recover. These guys are single cell organisms, so we're going to try to do damage to get rid of them. So your body will sacrifice its own cells in order to get rid of this. And quite literally, it will do that. Go and kill infected cells. So keep that in mind when we start talking about immunology in chapters 15 and 16. So most of your disease is going to be caused either from your immune system attacking or sometimes from toxins or enzymes that these bacteria will make. And that's usually their own defense mechanism. And then, of course, once you've established your setup, you set up your shop, you have avoided immune attacks, and now we've caught disease. Well, now you want to move on and maybe affect another guy. So that's about getting out. These guys can be spread out through air droplets that you might sneeze or cough out, through your urine, through your feces, through your blood, whatever it takes. All right, so let's move through these guys. Another place that we can have exchange of microbes is the placenta. We usually think of the placenta as being a barrier, but some microbes are able to cross it. Quorum sensing is another thing that I want to talk about, just to remind you guys. I know we've mentioned it before, but when you have biofilms forming, that the microbes that are involved in the biofilms and in these environments, that, well, they can sense basically the waste products or other signaling molecules in there that lets them know the health of the biofilm overall. Let them know if they want to still be part of it. We talk about the fimbriae for attaching, their little appendages on bacteria for attachment, the capsules, which is our sticky coating for attachment, and then our viral spikes that basically work to dock with proteins on our cell surfaces. Phagocytes are our white blood cells that eat up our bad guys. Anything that prevents phagocytosis from being successful. So this would be evading the phagocytosis, living inside of the phagocytes, preventing being killed by the phagocyte, or literally killing the phagocyte itself. These are all anti-phagocytic factors. These are virulence factors because they also are helping in development of disease. Right. Other virulence factors might include creating enzymes or toxins that can help with that bacteria or microbe, whatever it is, getting in deeper into tissues, things like that. So an example here that it's talking about would be secreted enzymes and toxins and things like that. Enzymes that are secreted outside of the cell are called exoenzymes. So these are enzymes that are literally made by bacteria that are secreted outside of the bacteria to help them usually get in deeper into tissues. That's like the number one thing. But this will break down and inflict damage on our tissues. A good one that they have down here is mucinase. So ACE, right? What does that say to you? It's an enzyme. Always. This is an enzyme that breaks down mucin. And what's mucin? If you know anything about mucinex, what's that make up? Mucus. Mucus is sticky and thick for a reason. It's meant to trap our microbes. So microbes that make mucinase, these guys have enzymes that break down mucus to allow them to still get to the tissues underneath so that they can't be affected as easily by your mucus defenses. We also have guys that make like hyaluronidase or collagenase, things that are part of your extracellular matrix that keep your tissues and your organs. And so it allow them to break down those junctions between your cells so they can get deeper into your tissues. So toxins are anything that these microbes make that cause damage to the host. So those might be enzymes. So exoenzymes can be toxins, but not all toxins are enzymes. So when we look at botulinum toxin, so from botulism, so botulinum or tetanospasmin toxin, these are toxins that are not enzymes, but they still have an effect on the host, causing damage. So paralysis, either that's flaccid or spastic paralysis, but those are toxins. They're made by these organisms and they are secreted outside of the organism. So they are exotoxins. So an exoenzyme that's causing damage to the host would also be an exotoxin. Okay. But not all toxins are enzymes, right? There is one kind of toxin that is always one thing, and that is endotoxin, all right? Endotoxin is always LPS on gram-negative cells. Always. That's all it is ever. So if we're ever talking about endotoxin, yes, endotoxin means it's part of the organism because it is the LPS, the lipopolysaccharide, on that outer membrane of the gram-negative. And it's called endotoxin. It's a toxin because it causes damage to the host. We're the host. And so, yes, we have plenty of gram-negative bacteria in our gut that we're not reacting to. Our immune system has been trained not to react to them there, but get those microbes in your bloodstream and see what happens. Pretty quick, your body's immune system will recognize that endotoxin in your blood and have a shock response to it. And you can die very quickly when you go into shock from response to endotoxin in the bloodstream. So it has its place. It should only be where it belongs. So hemolysis is another example of this. Hemolysis, hemo is blood, lysis, breaking these apart. We've talked about hemolysis before, so I'm not going to go into too much detail with this. But remember, gamma, we have growth on the blood, but we don't have any breakdown of the blood. Alpha, we have partial breakdown of the blood. And then beta, we have total. All right. Just reprise that. All right. So some pathogenicity or disease is associated with your host response. It's actually a pretty strong effect of it. Sometimes this can get so out of control that that can really just be like the driving force of the disease. We talk about long COVID. Long COVID is like almost always associated with having the immune system be overstimulated by the COVID virus. So that person's immune response against COVID was so strong and persistent that they continue to have symptoms of COVID even well after that virus is gone, specifically because their immune system isn't being downregulated. It just was so overstimulated that we continued to have that response for a longer period of time. There's also different patterns of infection that we can see associated once we establish infection. We can have localized infection, like what we see with a boil. Systemic infection is all over throughout the whole body. All right, focal infection is moving from one site to another. We haven't gone throughout the whole body. We just moved from one spot to another. So in this example, having a sinus infection and then ending up having endocarditis because the bacteria moved into the heart. Mixed infections, these guys are caused by various microbes. More than one microbe is involved. And we have primary and secondary infections. We kind of already just talked about this whenever we talked about like the flu and pneumonia. It was spelled very well, but the flu and pneumonia. So getting influenza, then influenza causes damage. It might create new stadium seats where there weren't spaces before for something to live in, but we caused so much damage. Now the microbes can come and live in that area, or by removing the old microbes or creating just the environment, making it different and allowing microbes from other areas of your body to come and inhabit the lungs, usually from the sinus cavities and from drainage associated with that. All right, this is just going over these things we already talked about. Oops. Acute versus chronic. Acute. These things come on rapidly and are usually short-lived. We also usually have stronger signs and symptoms associated with acute infections. Chronic infections, they progress slower and they're usually not as severe, but they last a long time. There's no like hard and fast rule about what makes something chronic versus acute. So it's not like if you have a sickness for 2 weeks, it automatically becomes chronic. It depends on the illness. So sometimes having, giardiasis, having traveler's diarrhea for a whole month, that's nothing unusual. That's acute still. But if you keep having that go on and on and on and on and on, then it might become what you would consider chronic for giardiasis. But again, having salmonella for that long and having diarrhea from salmonella for that long would be very concerning. Usually you're going to clear that out within a week or two. So it just depends on the disease. All right, let's talk about signs and symptoms. A sign, when I think of a sign, I think quite literally of a stop sign. So if I had a stop sign in here, would you be able to actually touch the stop sign? It's a physical object, right? You could actually handle a sign. If I say the same thing, if I had a symptom in here, can you come touch a symptom? That's a really vague idea. Now we're getting into this weird concept of like not sure, not sure. Well, that's how I remember the difference between these guys, okay? So a sign is something that is verifiable or measurable. And a symptom is something that is reported, but it isn't necessarily verifiable. So let me tell you the difference. If the patient has a fever, can you measure their temperature and verify that? Yeah, you've got a thermometer, you can do that. If the patient has swollen lymph nodes, can you palpate that? Yes, you can. You can show that it's swollen lymph nodes. If a patient's experiencing pain, can you verify that? No. Can you measure their pain? No. Can you measure their nausea? No. Can you measure their fatigue? No. Can you measure vomiting? No. Yes. See the difference? If you can measure it and verify it, it's a sign. If you can't measure it or verify it, it's a symptom. Okay. All right, moving on. Syndrome. Because I know this is one of those things that seems really obvious at first, but if I ask you guys, if you take someone's blood and you measure that they have a high white blood cell count, is that a sign or a symptom? Sign. Measure that, right? Patient comes in saying that they have a migraine. Is that a sign or a symptom? Symptom. You can't measure how much that they're actually in pain. Right? That doesn't make them any less significant. It just means that they're called something else. So sometimes patients will come in faking symptoms, but you can't fake a sign. You just can't. Now, if you're going into veterinary medicine, congratulations. Your pets, the pets that you're treating won't lie to you about this, generally speaking. Now there will be chihuahuas that will come in there screaming and crying because you went to go pick them up because you touched them. They're not experiencing any freaking pain. They're just being dramatic, right? So sometimes there's a little bit of overlap there, but in general, animals are going to be a lot more honest and a lot more readable. Signs, right? Some pets won't give you anything. Like one of my students was talking about, she works in a vet clinic and she had a dog that was brought in, it had a fracture that was poking through its skin. It was just living its life like its best life. But there's a sign there that says that they've got a bone protruding from their skin, and you know for sure they've got a wound there. And so you would definitely mark that, and you probably assume that that dog would be in pain. But if a person comes into the ER and they're talking about how much pain, oh my God, I'm in so much pain. Y'all, I've been in some ERs as a patient seeing these assholes that are just there for the medication. They'll come in there crying and crying, and they're in so much pain. They're sitting there, oh my God, I'm in so much pain, I can't handle it. And when the nurses aren't looking, they're just on their phone, like, they're just fine. They're not sweating. They're not in pain. And then meanwhile, those of us who are like, we're actually in pain are like sitting there sweating, like throwing up into the bag and everything like this. Like, I am judging a little bit, but it won't matter when you guys are in the healthcare field, will it? Because whenever somebody comes to you telling you that they're in pain, you have to treat them like they're in pain. You don't get to say. So anyways, difference between signs and symptoms. Then we have syndromes. Syndromes are defined by their signs and symptoms, not by what causes the disease. This is actually something that you're more familiar with than you probably think. The flu, what causes the flu? The influenza virus, right? COVID, what causes COVID? COVID-19, right? The SARS-CoV-2 virus. All right, so we talk about the common cold. What causes the common cold? Well, as it turns out, there's 200 different viruses that can cause the common cold. So we define the common cold as having a runny nose, there might be some stuffy nose too, having sinus issues, having maybe a little bit of mild sore throat. You might be tired or fatigued. You might have a cough, but you generally won't have a fever. If you do, it's very low grade. And you generally won't have the muscle soreness, the malaise, and the severe fatigue that comes along with the flu, right? Having a common cold, you have a whole bunch of different crap that can cause a common cold. Having meningitis, there's a whole bunch of stuff that can cause meningitis. There's this whole slew of bacteria, there's several fungus, there's a whole ton of viruses that can cause meningitis. But meningitis is still defined as having photophobia, having swollen meninges, that's really what it is inflamed meninges. But the signs and symptoms associated with that will be photophobia, which is light sensitivity, stiffness in the neck, headache, and a fever, typically. Yeah, you can lose memory, that can even be permanent. Yeah, that can be permanent. And so we'll actually talk about that next, which is talking about sequelae and latency and stuff like that. Infections can be asymptomatic, subclinical, or inapparent. We know what subclinical is. Y'all ever had like the flu or something and you're getting better, but you still have a little bit of a sore throat or a runny nose? You're not completely over it, but it's not something worth going to the doctor over. Anytime you felt a little ill, but it's not worth going to the doctor over, that's subclinical. Okay. Asymptomatic, we know what that is. You can be infected with something and not actually have the symptoms. Like we said, a third of people with COVID walking around without any symptoms at all. All right, once you have established infection, you need to get out. I'm not going to go over that because I feel like it's pretty self-explanatory. Latency, whenever an infection becomes dormant in the body. This could be by hiding out in the DNA, which we've talked about, like with HIV or with chickenpox or herpes or whatever. But this could also be done by bacteria, like whenever we talk about tuberculosis. In tuberculosis, that bacteria gets eaten up by your white blood cells, and it just stays there like that. And it can stay there like that for like a decade or so. And then something happens where your immune system gets stressed, and it'll start growing again, and then it leads to the development of secondary tuberculosis, also known as consumption. So that's when you start coughing up the blood and having what we consider to be the characteristic signs and symptoms of tuberculosis. Most people have primary tuberculosis where they have no signs or symptoms, and then that's followed by latency. That's actually why if you go work in a hospital, you have to get tested for tuberculosis, usually twice, because those are kind of unreliable tests. So you could literally be carrying it around right now and just not know. There's been an outbreak recently in Kansas, tuberculosis. All right, sequelae. This is long-term effects like losing your memory from having meningitis. So you're also very, very common to lose hearing during meningitis. You can become deaf permanently. The obvious one, of course, will be with polio. We know FDR was in a wheelchair because of polio. He didn't have polio while he was president. He was over the polio by then. But that paralysis from the polio stuck with him for his lifetime. So those are called sequelae. The phases for the course of infection basically align with our bacterial growth curves pretty closely. So this first stage, what we call the lag phase, where the organisms were adjusting, this is basically when the incubation period happens. The organisms are getting acclimated. They're finding the site where they want to grow up and become an infection, but they haven't quite gotten there yet, and the immune system hasn't detected them, so we don't have signs or symptoms yet. Then we have the exponential phase. This is associated early on with the prodrome. This is when you first have your very first signs or symptoms. Like when you guys have spent a long day working at a hospital or a clinic, and you start getting that tickle in the back of your throat, you start to feel tired and a little sore, and you just know you're about to come down with something. That's the prodrome. The very, very, very first signs and symptoms of the illness, prodrome. Then this later period of the exponential phase, plus please go away, plus the stationary phase. This is where we have our acute phase of the illness. This is where you have full-blown flu, right? You're having the worst of it. That's the acute phase. And then during the death phase of the growth curve is when we have convalescence. You are convalescent whenever you start having a decrease in the infection numbers and you start having easing up of your signs and symptoms. Start feeling better. You might not be fully over it yet, but you start feeling better. That's in the convalescent. There's a little graph there that compares it if you are interested. All right, so reservoir, sources, and carriers. That's basically what the next slide is going to be over is the carriers. The reservoir is where this infection is maintained naturally in the wild, let's say. So when we talk about Ebola exists within probably, we haven't proved it for sure, but probably bat populations in sub-Saharan Africa. So in these tropical areas, bats actually have Ebola growing in them, but they don't have any signs or symptoms. This is just a natural part of their existence. And then these bats can then transmit Ebola to, let's say, primates, monkeys that are in these areas. And then tribes in those areas might go hunting for bushmeat, and they go shoot and kill one of these monkeys. And when they're butchering the monkey, they get exposed to the Ebola virus, and now they're sick. The reservoir would be the bats. The source would be the monkey. Okay? That Ebola is not maintained silently within the monkey population. Those monkeys have Ebola, just like the people do. They're bleeding out, and they are sick, and they're not doing well. So they are not reservoirs. They're also not carriers. A carrier is an individual who can be infected, but not have signs or symptoms, or they're subclinical. So whenever you very, very first having your prodrome, where you feel a tickle in your throat, but you're still going to work, you're a carrier, all right? Or maybe you're one of the 1 in 3 people with COVID that don't ever have any signs or symptoms. You're a carrier. Or after you've had the flu and you start feeling better, but you got to go back to work because we got to make a paycheck and take care of our kids and pay our mortgage, that is going to be someone who's convalescent carrier, all right? And then the difference between that and the source is just wherever you got the infection from. They may have had symptoms or not, but wherever you got it from, that's the source. We have types of vectors as well. A vector is something that can transmit the disease to people, for example. And so we have living vectors that can be biological vectors or mechanical. We also have non-living vectors we'll talk about in a moment. A biological vector is something that's infected. So mosquitoes, when we talk about malaria, mosquitoes are actually infected with malaria. They're not just carrying blood that has malaria in it, they're actually actively infected with malaria. So they are biological vectors. The chickens that have the bird flu, these guys, biological vectors, they're infected. Bats with Ebola, they're infected, but they're vectors, right? We talk about cockroaches and flies. They'll run across through garbage, through feces, and all of this other nasty, rotten stuff, and then come and run on your food and could make you sick that way. So they are mechanical vectors. So they are not actually infected. They're just carrying, literally physically carrying that disease around that way. Mechanical. A zoonosis is any kind of disease that can be transmitted from animals to humans. This includes things like rabies, obvious one, right? But the flu, sorry, what? Leptospirosis is a good one as well. Very commonly spread throughout the animal population, but people can get that too. I don't feel like people are aware of that enough, honestly, if I'm completely serious. Right, that's the whole reason why we vaccinate for rabies as well, right? We think it's a problem with animals, but we're also protecting the human populations by vaccinating our animals. Same thing with lepto, which lepto can easily be deadly, and people, I want to be very clear about that too. It's not a minor disease. So lepto, rabies, but we can also include influenza in there. It's actually maintained within the avian and swine populations. Rocky Mountain spotted fever, it's maintained within dogs, the deer populations, and then transmitted from them to people via ticks. So all sorts of stuff like that. A communicable disease can be transmitted between people. If it's really easily transmitted between people, we call it contagious. A non-communicable disease is something that wouldn't be transmitted from person to person. Sometimes we have a hard time considering this. So obviously there's the non-infectious related ones like cancer. That would be an obvious one, right? But another one that we can talk about that's non-communicable, that's infectious, would be like a UTI. You guys aren't going to get my UTI, right? It's non-communicable. Ways that things can be transmitted. Horizontal is like from person to person, whereas vertical is from parental to child. This could be genetically related, or it could be from being in the uterus of maybe a mother that has herpes or something and being exposed to that during birth. That would be vertical transmission. So parent to child. A vehicle, anything that could be used to transmit a pathogen. If it is an inanimate object that itself doesn't actually serve as the source of the pathogen, but could be, I keep holding the pen up, but like imagine I was handling this whole time and I had COVID. And then you guys came up here and picked this up. Does the pen have COVID? No, it's not infected with COVID, but it's contaminated with it, right? So this is a vehicle. It's specifically because it's only transiently exposed to the disease. We call it a fomite. That's the word for it. Oral fecal route of transmission, obvious one, right? Poo-poo to mouth, right? If you don't wash your hands before going to the bathroom and then handling somebody's food, that's where this issue will come from. Cholera is a great example of that. And obviously, organisms can be transmitted through moisture. And usually in air, we're talking most about droplets or dried particles. This would be our droplet nuclei and our aerosols. Robert Koch came up with some steps and rules that are basically involved in figuring out the cause of disease. If you take a sample from a sick individual and you isolate the organism you think is causing it, infect another person or organism with it, and then can re-isolate it, then that is the cause of the disease. He discovered anthrax this way. Really quick, starting off with epidemiology, because this is the study of the spread of disease within population that could be infectious or not. So even looking at cancer and spread of cancer would be epidemiology. Two people that we need to know about in epidemiology, Florence Nightingale and John Snow. Florence Nightingale is known as the mother of nursing. She was the one that basically discovered during the Crimean War that patients were being brought in with stab wounds, but dying of dysentery. You don't get dysentery from stab wounds. She was wondering what that was all about. As it turns out, all she had to do was have the staff wash their hands occasionally between patients. And that cut down the deaths dramatically. Mother of nursing. John Snow, he discovered that people were coming down with cholera in London. What he noticed was that he mapped out all the illness on his map and centered around a center. And that center happens to be the water pump for that area in Soho, London. So he told people that they need to stop drinking from it because you're spreading cholera between people through that water pump. Well, people kept drinking from it, so he just took the handle off. And lo and behold, cholera stopped spreading. Cholera is an oral fecal route transmission. It's a diarrheal disease. All right, here we go with terms. Y'all ready? Okay. Prevalence, the number of existing cases total within the total population. So we're talking about the total number of people being affected by the disease. Whereas incidence or morbidity, they're the same thing. Incidence and morbidity are the same thing. You ever heard of maybe hospitals or perhaps the CDC coming out with a morbidity mortality report for the week? It's going to be the number of cases you saw that week. So this is defined in a time period. So the number of cases in a specific time period. So in this week or in this month, incidence or morbidity. Mortality is death rate. Okay. Different kinds of epidemics you can have. Point source epidemic. If I came in here with COVID and I coughed all over all of you and you all got COVID, you would know exactly what time, place, and means you got your COVID from. We could point at Professor Yost as being the source in that moment, in that specific point in time. That's a point source epidemic. Common source epidemic. Let's go back to John Snow back in London. All these people were coming to this water pump for water. They didn't all get exposed at the exact same time. People were coming to that water pump over days and days and days, but it was all the same source that was contaminated. That's common source. Point source, one single point of exposure in time. Common source, people are being exposed over time, but it's all from one source. The third one, type of epidemics. We have point source, one point in time. Common source, one source, but exposed over time. And we have propagated epidemics. That's our third one. COVID is being maintained within the human population right now. It might come in waves, come and go, but we are keeping it in the human population. We've kept it in the human population for years. That's a propagated epidemic. It's being maintained within the population. It just fluctuates. The index case is the first person to get sick. If a disease is endemic, that means we expect it to see at a certain level in the population. So if one or two people came down with a cold right now, would anybody be surprised? Probably not. Pretty common, especially in winter to springtime. But if we went home and then we suddenly got a call from Professor Yost that everybody in this room came down with tuberculosis, we'd probably be pretty surprised by that, right? So endemic is the amount that you're used to seeing normally, right? An epidemic is when it exceeds that. But when you exceed the amount that you're used to seeing, that's an epidemic. And that could be even zero. If you're used to seeing zero, and now you have any, that could still be constituted as an epidemic, as long as we have multiple cases that are involved. Because if it's just one case, I go home and I'm stupid and there's a raccoon in my yard attacking my dog and it bites me and then I end up getting rabies from that, that's a sporadic case, right? That's not going to cause an epidemic. That's just a sporadic random case. A pandemic is an epidemic that crosses continents, okay? Screening tests are used basically as non-invasive procedures to quickly assess the likelihood that somebody has a disease. They're going to be lower accuracy and higher cost than typical diagnostic tests. Okay, so your home COVID test versus the PCR test. Home COVID test is cheaper, but also less reliable than the PCR test, but you can screen pretty quickly. Now, if you're positive for COVID on the home test, you're positive. But if you're negative at home on the home test, there's a little leeway there. We might not know for sure, right? Pap smears are kind of the same way. They're a screening test. They don't assess 100% certainty your likelihood of ever having cancer or having had the cancer, but the likelihood in this moment right there while they're looking at you that you seem to be presenting with the cancer. That's a screening test. Screening tests are basically defined by their specificity and their sensitivity. We want tests to be both of these things, but they're two different sides of the test. Imagine that you're somebody that's very sensitive to critique and somebody else who's less sensitive to critique, right? You could shout all this stuff at them and they're like, yeah, sure, it's whatever. If you're really sensitive, you're going to pick up on all that innuendo. It's like, oh, she sounded really mad at me. Oh, she sounded like she hated my presentation. Oh, this person, whatever. You're sensitive, you're going to pick up on all of those cues. Same thing with sensitive tests. If you're a sensitive test, you're going to pick up on any positive, even the really weak positives. There might only be a few viruses there. If you're really sensitive, you'll be able to pick it up. Okay, so sensitivity, eliminating false negatives. A false negative is when you call something negative, but it's positive. Okay, so the more sensitive you are, the less false negatives. Specificity is the other side of that coin. You want to recognize positives, but you don't want to say that something's positive when it's not. So an example would be looking at somebody's symptoms and saying, I want to look for all the people that have a cold versus the flu. Well, there's a lot of overlap in that. So the likelihood, if you're just looking at signs and symptoms, that you might call something the cold or the flu, it's going to be really hard to discern. And so we want a test that would be able to pick out definitely cold versus definitely flu. So that's specificity. So you don't want to call something positive when it's not. It might look similar, but we don't want to accidentally call it positive. That's specificity. And so that would be a false positive if we call something positive when it's not. So specificity, we want to eliminate as many false positives as possible. Sensitivity, eliminate as many false negatives as possible. And obviously you want both and as high as much as you can, right? That's what we want in our tests. All right, now we need to figure out the cause of our diseases. We're almost there, y'all. There are 3 major kinds of studies that epidemiologists will do. So we already talked about different kinds of epidemics. There's 3 of those as well. Just 3 different kinds of studies epidemiologists can do to look at the cause of an epidemic. Cross-sectional, just like we saw with our point source epidemics. Remember our point source epidemic was an epidemic that we know started from one particular exposure at one time. Well, our cross-sectional studies is taking a look at, let's say everybody gets sick. We're going to take that one point in time and gather the data from everybody at that one point in time. It doesn't look at what's happening to what happened first or later. It's only looking at that one point in time as it is. Okay, so that's a cross-sectional study looking at a point in time. Okay, gathering data from that point. Case control, it says in the name what it is. Looking at cases versus control group. Cases, people who are sick versus control, people who are not. And then comparing data from the people who are sick to the people who are not. That's a case control study. Then finally, our last one is the cohort study. I already told you guys that I smoke cigarettes. So taking people like myself and my mom and my mom's whole family, which is where I got it from, bad habits and all their bad habits, and then taking people who don't smoke and looking at them over time and the incidence of lung cancer in those populations would be a cohort study. Okay, make sense? So taking people who don't have the disease, nobody has it, but there's groups of people that would be likely to have it versus not likely, you think, and looking at them over time and then looking at the results there. I feel like the lung cancer one is a really easy one to put that into perspective with. We also want to track our diseases and notify our government as is required. There are governmental agencies that require you to report certain things. If you work in a hospital, there are certain kinds of infections that are actually incredibly common. And so often hospitals will track these within the hospital. This will be catheter-associated infections, very, very common. In fact, Dr. Shearer was just telling me a story about how his wife was in the hospital for something very minor, but she needed a basic catheter done. She saw the nurse get the catheter out of the packet and it fell on the floor, and the nurse picked it up and went to go put the catheter in. And Dr. Shearer called her out on it. If you're ever that person, I will get you fired. Okay? Don't be that person. I'm watching, and so is Dr. Shearer. All right, don't be that person. It's not worth somebody's life. These are incredibly common infections, and you can die from these things. So you're putting something up into somebody's body that shouldn't be exposed to bacteria that's on like the floor. Disgusting. Have we already learned how nasty our shoes and the floor is? Gross. So central line infections, incredibly difficult to maintain these. We're talking about something that's embedded into the body for a very long period of time, and maintaining sterility where your bloodstream is sterile. Maintaining sterility into that port of entry is incredibly difficult. Surgical site infections. We're going to try to keep these things as clean as we can in a hospital, but a lot of it depends on the patient's self-care. The patients just aren't great at self-care. So there's issues with that. Ventilator-associated events. If you are on a ventilator, if you get pneumonia when you're on a ventilator in a hospital, the death rate is somewhere around 50 to 60% mortality rate. 50 to 60% chance that you're going to die if you get pneumonia when you're on a ventilator in a hospital. You're in a freaking hospital. And this is associated with just the fact that the patient isn't setting up to help with proper cleaning of the lungs. They can't cough for themselves. They can't mobilize and get their lymph system moving, just things like this. It just predisposes these people, and then giving a direct access of microbes into these tissues. So these are really difficult situations, and a lot of this is monitored by the hospital's infection control officer. They'll maintain cleanliness in the hospital by following the procedures associated with whatever area you're working in. Medical asepsis, this is changing your PPE, sanitizing surfaces, sterilizing where you can, hand washing and things like that. But we can't keep the environment around where the patient is just normally existing completely sterile. But in surgical sepsis, we try to keep everything as sterile as possible. So that means completely microbe free, entirely 100% life free. Okay, so that's what surgical asepsis is about. We want sterility for that. It's impossible to maintain that in normal medical environments though. All right. R naught, which we call R sub zero, but on exams or on your quizzes, I'll call it R naught, okay? This is a term that's associated with how many people you're likely to get infected with your disease. It usually has to deal with communicability, right? So how contagious something is. So with COVID, it's something like 5. If you get COVID, you're likely to infect 5 people. That's just the normal average for that. That's not really the case with like Ebola. Ebola is not incredibly like communicable. It might be less than 1. Like most people with Ebola aren't going to infect another person. So it's just unlikely that it'll happen, right? So it just depends on the disease, what your R naught is. The more communicable, the more contagious a disease is, the higher that R naught, right? Case fatality rate, the likelihood that you're going to die from a disease if you get the disease. So if you get rabies, it's 100% fatal. There's not even treatment that's going to save you from that. But we talked about HIV. HIV can be really pretty easily maintained with treatment, but without treatment, it's 100% fatal. So its case fatality rate is 100%. Okay? We're talking about without treatment. There's some charts that are comparing fatality rate to communicability, which is R naught, if you are interested in looking at comparisons there. And then finally, we're going to get into vaccines. Vaccines are important for maintaining immunity within a population. There are populations of people in our society that cannot be vaccinated. They either have immune responses that are unhealthy, they have genetic defects that make it so they cannot be vaccinated, or they're little tiny babies, they don't have an immune system of their own yet. If you're under 6 months old, you're at incredibly high risk for diseases you don't have the ability to build up your own immunity for. Also, if you're very, very old, your immune system is failing. So it's on the rest of us who can get vaccinated to be protective for the rest of those in our population. We have an outbreak of measles here in Oklahoma right now because of anti-vax movement. It is their responsibility of people who can get vaccinated to be vaccinated. We have taken it for granted not seeing measles here in this state because vaccines are so effective for the MMR. In fact, you usually get 1 vaccine set when you're a little kid, and you're usually set for life with that. People just have been taking it for granted. And now we have people, your vaccine doesn't always last forever. When you guys go into nursing school, you'll have to get your titers checked. Just make sure that your immunity is still high enough from your vaccines. I had a student, my best student of all time, who just got into nursing school, and her titers were low for MMR, so she has to go through the vaccine series again. So she's somebody who her immunity just wasn't as strong to that vaccine as other people's may have been. That means that if she hadn't got her titers checked, she could have got measles from these people that are walking around that aren't getting vaccinated, and their kids that aren't getting vaccinated. And now these kids might just have the measles. It's not a super serious disease for most people. But now imagine you just had a brand new newborn baby that you just took home from the hospital yesterday. And now your cousin brings over their babies to come see and visit the new baby. And those kids had the measles and they didn't tell you. Because the measles is nothing, but your little baby could die from it easily. Meningitis or encephalitis. Measles is not to be trifled with. And it is one of the most contagious diseases on the planet. We need 95 to 97% of the population to be vaccinated for measles to protect those who can't get vaccinated. That's herd immunity. Okay. We lower for less communicable diseases. Here's a chart that explains that. An emerging disease is something that's new to us. Re-emerging, something that was old, it's coming back again. Tuberculosis, for example. Neglected parasitic diseases include some of the things that we don't think about here in the United States, like toxoplasmosis and some stuff that we're going to learn about in later chapters. We do have these diseases here in the US. All of these are present in the United States. By the way, these are parasitic diseases that usually don't get studied well because they're usually not an issue for people who are, we'll say, I don't want to say wealthy because that's not right at all, but people who are poor, are in the lower end of the monetary spectrum that don't get very good care and don't know much about hygiene or can't maintain their hygiene the same are at a higher risk for these diseases. And so we call them neglected because they're neglected because money. Bioterrorism, using biology type stuff to attack people, like with anthrax and stuff like that. And then agroterrorism, just be like attacking livestock and stuff like that with biological warfare.